Okay, welcome back. I apologize. Okay, so I know this is review. What's a pulmonary embolism?
Obstruction, blood flow to the arteries.
Okay, but what is that obstruction?
Blood clot.
Usually a blood clot. Now, what are some of the other causes of a pulmonary embolism?
An air bubble.
Okay, so an air embolism.
Or a fat particle or foreign body.
Okay, a fat embolism. What else?
Amniotic fluid.
Amniotic fluid. Okay, that's in the kid, or yeah, it can go into the mother. What else? I mean, what can cause it? Excuse me.
Bless you.
Thank you.
A foreign body, like something that's obstructing it.
Okay. What else?
Trauma.
Okay. How?
Being hit in the chest cavity.
But how's that going to cause a
Or the
clot?
Inflammation. Can it cause inflammation?
But I'm trying to understand the pathophysiology of what you're telling me. So how is it a clot? How is a clot being formed with that chest trauma?
It causes the arteries to be inflamed. They're blocking.
No. If they're, are you talking about arteries being dilated or constricted?
Constricted.
But how is that an embolus?
I can understand if it was like if a patient was in a mobile accident or their other organs of their veins like got cut off, then say like the steering wheel is on your legs and it's cutting off blood to your and can form a clot in your leg.
If you break a bone, yeah, you could cause a clot. Especially once it's been set, you release a fat embolism. Yes. As far as sitting down for prolonged periods of time, I think I talked about this where you're constricting the blood vessels. So what's happening to the blood flow through that blood vessel?
It's minimizing.
It's minimizing it. It's reducing it. So what happens to that blood that's not going through?
It's getting backed up.
And
Causing the blood clot.
But it's not. It's the backup, but it's not the backup.
Yeah.
The pressure.
It's not the pressure.
No.
Again, this is stuff we've already covered. Remember we talked about it in shock?
Yes.
And this is a type of, what kind of shock?
Obstructive shock.
Obstructive shock. So as that blood sits there, it becomes stagnant and begins to coagulate, clump up.
Yes.
So that's what I was looking for.
Oh, right.
Where that blood becomes stagnant and starts to clump together. Okay. Who else is susceptible to blood clots?
Who else is what?
Who else is susceptible to blood clots? So in a way, it's travelers that they go on long trips, whether sitting in a car or sitting in an airplane.
It can be like people that are bedridden,
Okay.
heart disease, recent surgeries,
Uh-huh.
long bone fractures, pregnancy, cancer, deep vein, thermomorbus.
Thrombus, okay. What about females on birth control,
Yes.
especially if they smoke?
Yeah.
Can you explain?
What was that?
Can you explain?
Yeah, please.
Well, the birth control is altering their hormone levels.
Mm-hmm.
And so with smoking, smoking causes vasoconstriction.
Oh,
Yes.
okay.
Therefore reducing blood flow, causing a clot.
Thank you.
Uh-huh. All right. Oh, great. Now my PowerPoint doesn't work.
I had a thrombosis, deep vein from my side going up to like my nipple,
Uh-huh.
like right under my nipple, and that thing hurt whenever I would stretch. I can't remember what they did for it, but that thing like really hurt when I would stretch.
My dad last year had 2 DVTs, deep vein thrombosis, in his legs because he sat at his sofa a lot. And I do think about me getting clots because I do sit a lot for at my job. I mean, I'm sitting in front of a computer for 8 hours a day when I teach. And then when I'm not teaching, I'm sitting on my desk working.
Mm-hmm.
The good thing is that I am on blood thinners. I'm on Plavix.
I got that when I was transporting patients a lot, so I was always driving. Like,
Yeah, because you're sitting down for a long period of time.
mm-hmm.
Okay. So what are the signs and symptoms we're going to see with a pulmonary embolism?
Difficult breathing.
Okay.
Oh,
Sudden
yeah.
onset of difficulty breathing. What else?
Tachycardia.
Okay.
Off.
What are the breath sounds going to be?
Like sharp, like sudden. Not sharp.
Shallow?
Like a crackling sound, right?
Is this a airway issue or is this a circulatory
No.
issue?
Circulatory.
Boy.
Gonna be
Circulatory. So
Circulatory.
is it going to affect the airflow through the lungs?
no.
No. Remember, the blockage is not occurring with the bronchioles or the alveoli. It's occurring in the circulatory system.
Yes.
So it's going to be the arterioles, the venules, the capillaries.
All the other stuff. Yeah.
Uh-huh. Okay, so that's important to remember. So you might not, or you won't hear anything.
No.
Usually what they do is they give a blood thinner. And for others, when they have a DVT, they could also put like a filter, a mesh to capture that in case it becomes dislodged. Because a DVT is just a clot that's built up, but it hasn't gone anywhere else.
Yeah.
So that's why they'll put that mesh there to try to catch it. If it becomes dislodged, then it's there to catch it. It's kind of like one of those nets on an aircraft carrier. If that jet doesn't hit the wire, then there's that safety net to catch that jet. It's the same thing here in that case. Okay. What do you think the treatment is?
Well, that blood thinners?
Like you said, the blood thinners and
But can we give blood thinners?
No, we can't.
No.
No.
Oxygen?
Oxygen?
Yeah.
Diesel therapy? Prayer?
Prayer. Prayer.
Yeah. That's what a buddy of mine, colleague of mine, taught us. We would teach.
That's a good one.
All right. So talk to me about pulmonary edema.
Usually in the legs, no?
It's a clot
It's what?
in your lungs.
It's usually in the lung. Oh, no, sorry.
Pulmonary edema.
Buildup of fluids in the lung.
Okay, build up a fluid in the lung. Okay, good. What else? So it's the same thing that we talked about with pneumonia, right? About fluid not being able to diffuse oxygen.
Yeah.
So, all right. What else? What's causing that pulmonary edema?
Aspiration of vomits.
That what? I'm sorry.
It can be caused by like ammonia, aspiration, narcotic overdose, inhaling of smoke.
Okay, so something's causing the leakage of fluid into the lungs.
Yes.
Can it be by CHF?
Yes. Yes, sir. So what are we going to find with that patient with CHF? I'm sorry, with pulmonary edema?
Barrel chest, maybe?
No, that's emphysema.
Oh, that's right.
What are the lung sounds going to be?
Wheezing.
Nope.
Shallow.
Crackles.
Okay, the lung sounds are going to reveal crackles, bubbling of fluid in the lungs. So the respirations can be shallow, could be rapid, right? What do you think the pulse ox is going to be?
Less than 94.
Less than 94.
Okay, so it's going to be low. So what can you do for treatment?
Increase hospital pressure.
Okay, so BVM or
Prevent more fluids from entering the alveoli.
how do we do that?
Suction.
Well, we can't get the catheter way down into the alveoli to suction out that fluid.
Well, you can turn them on their side.
I don't want to lay them down.
On their
So let me give you a visual. Let me give you a patient. You walk in. The patient is either on the recliner, they have to sleep on the recliner, Or if they're in bed, they have about 3, 4, 5 pillows and they sleep upright. Okay. So what is that a sign of? And what do we call it? First off, what's that a sign of? What are we talking about?
Fluid
I'm
buildup.
sitting up.
Tripoding?
No, tripoding is leaning forward. This is just, they're laying in bed and they have to use multiple pillows in order to sit up to breathe. What do we call that? And why is that occurring?
Recovery position.
No, recovery position is laying on a lot of recumbent.
This has to do with the
Comfort.
snoring.
So here's what?
Like the snoring, the airway.
Not necessarily snoring. No, it's not a snoring thing.
No.
Is you guys keep saying laying him down. Here's the problem. There's fluid in the lungs. So when you lay him down, that fluid is spread over a wider area. So you're literally drowning them to death by spreading that fluid throughout. So your patient needs to be sitting up, semi-Fowlers or even high Fowlers. So when you walk into that living room or into that bedroom and you see the patient, if in the bedroom they're sitting up in bed with all these pillows because they can't breathe otherwise, or if they're in their recliner and they have to sleep in the recliner because they can't be laying down flat because, again, they feel like they're drowning, that's called orthopnea. Ortho and then pnea, P-N-E-A, orthopnea.
Oh,
That means that they have to sleep sitting up because otherwise they cannot breathe because of the fluid in the lungs. So yeah, Sequoia, what I was trying to get you to say is CPAP.
Oh.
Okay.
All right, the next thing. The next thing is a spontaneous pneumothorax. So we've talked about a pneumothorax, which is what?
It's the sudden rupture of a portion of the lung.
Okay.
It's like when it collapsed, kind of.
Well, it could be a rupture of the lung. It could be a rupture of the visceral pleura, where air is leaking out of the lung, and it's causing it to collapse. The lung is collapsing. That's a pneumothorax, where there's air in the chest cavity. Now, spontaneous means it just happened, like spontaneous combustion. It just happened. Here, that's what happened too. It could be what we call pathology or disease process of the lung, which weakens it and it causes it to burst. Another thing could be excessive coughing, can cause a spontaneous pneumothorax. And then here's another one to think about. Is a tall, slender Caucasian male. For some reason, they're very susceptible to spontaneous pneumothorax. So, who knows? All right, what else? So, how are they going to present?
Shortness of breath.
Shortness of breath.
chest pain.
Chest pain.
Chest pain.
Shoulder pain.
Pulse
Maybe
ox
chest
below.
Okay.
Yeah.
Sharp pains in the chest.
Okay. Is the lung collapsed?
Yeah, so you'll hear like decreased breath sounds on one side of the lung, on one of them.
Run that by me again, I'm sorry.
You'll hear decreased breath of sounds on one side of the chest since one of the lungs is collapsed.
Decreased to what? Absent.
It's
If the
collapsed.
lung is collapsed, are you going to hear air exchange?
No.
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 So how do we treat it?
Administer oxygen.
Oxygen.
How?
EVM.
Yeah.
BVM. Are you going to use CPAP?
No.
No. Yeah.
Contraindicated. Using continuous positive airway pressure. So, and you have a hole in the lung, so what's going to happen?
It worsens it.
It's going to worsen it. Okay. Now, I was gonna use Paul as my patient, but I'm gonna change it up. So he's at work, and he has this new person that just processed in, and he's freaking out like a little girl. I was gonna use a different word, but I was careful.
And we would have.
Uh-huh.
I said we would have.
Uh-huh. But there's ladies around, they'll kick my butt.
Yeah.
So so he starts freaking out because Bubba already has his eye on him. And so he starts breathing faster. What's going on?
He's getting nervous.
Hyperventilation.
Yeah, he's nervous, so he starts hyperventilating, right?
Yep.
So what's
Yeah.
happening to his respiratory rate?
It's increasing.
Increasing.
Okay.
There's a lot of pause there.
It's what?
There's a lot of pause there.
Dang.
A lot of problems?
No.
Yeah.
Pause.
Wait, what?
Yeah, I still couldn't hear it. He
Yeah.
kind of cuts out at the last moment.
I
There's
think
a lot of pause.
pause there. That we're
Well, a
answering
lot
the question.
Paul?
Yeah, that we're answering the question.
Ah. Oh, true. So he's breathing faster and deeper. So what's happening to his carbon dioxide level?
It's increasing.
It's what?
Is it increasing?
Nope.
Decreasing?
It's decreasing.
Oh yeah, yeah, because he's breathing more, right? He's breathing
Yep.
more. Yeah.
So that's why they used to give a paper bag to breathe in more carbon dioxide. However, we don't do that anymore. Okay. Now, one of the things that's going to happen is they might have cramping in the feet and the hands, and we call that carpal pedal spasm. Carpal, CARPAL,
Yeah.
and then pedal, PEDAL, spasm. So basically, the hands curl up, and then their feet also might contort. It's like, have you ever had a muscle cramp down your feet, down your toes?
No.
Thanks for.
Yeah, it's not fun. The other thing is they can feel numbness and tingling around the mouth.
That's almost happened to me once.
Uh,
My back got all tingly though. My whole like back was tingly.
yeah, you can also get chest pain. And so that's why I tell you guys, and we'll talk about it tomorrow. Women of childbearing age complaining of chest pain, odds are pretty good it's not a cardiac event. It's usually a psych event, behavioral emergency. They're having a panic attack or an anxiety attack. So, What else? So main thing you want to do is you want to calm them down. And so Paul putting his hand on the kid's shoulder, probably not going to be a good idea. Just kidding, Paul.
No. If I could just say, God, talk to him.
So you want to try and calm them down. Try to control their breathing. Have them slow down, have them follow you, talk to them. And we'll talk more about this in behavioral emergencies. But just have them slow down their breathing and even have them follow you. Say, all right, slow down. Take a deep breath and let it out. Slow. Deep breath, let it out. It's called the talk down technique.
Yeah.
You may administer oxygen, usually the nasal cannula.
When does it get to, is that just when they cannot stop? Hyperventilating? Is that when they just can't control it?
Yeah. Yep. And that's where you gotta talk to them, calm them down. All right, what's epiglottitis?
Information.
Okay. The big thing to know about epiglottitis, it's a bacterial infection that causes inflammation of the epiglottis. And what is the purpose of the epiglottis? What is the purpose of the epiglottis? What is the purpose of the epiglottis?
It's the opening of the larynx.
Well, it's located at the opening. It's a leaf-like structure that covers up the opening of the trachea that prevents food and water from going down the trachea.
Okay.
Okay. So if the epiglottis is swollen, what can happen?
You can get infected.
Okay, it's infected, but tell me the outcome of an infected epiglottis.
But it starts swelling. Like
What?
It's swelling.
Swollen?
Like it'll cut off your.
The airway will get compromised?
Exactly. If it's swollen, it's going to compromise your trachea, reducing the amount of air that can go down the trachea. So it can lead to death. Best thing is just give them oxygen, get them to the hospital. They need antibiotics. Where what?
Sorry, is that the one where you can't really make them open their mouth because it could close more?
That I hadn't heard of before.
Oh, I think you're talking about like seizures or something. No. Like they swallowed it.
I don't remember. I'll get back to you on that one.
Okay. The other thing, the way to kind of differentiate epiglottis from the others is that there's drooling involved. The patient will drool a lot. Now, it primarily afflicts. What was that?
That's a late sign.
But still, it's a way to differentiate it from the others.
Is that just when it starts complaining?
When what?
Is that just when the inflammation starts coming around? Like when it starts building up, that the drooling starts?
Well, like Sequoia said, it's a late sign, so it's going to be coming around later on. But it's a way to tell if they have epiglottitis versus croup or something else. Because again, it's a bacterial infection of the epiglottis. It primarily afflicts kids, usually about 3 to 6, 3 to 7. Although it can afflict adults as well, but primarily a pediatric issue.
Is it just because that they're still developing, or?
Well, their immune system's still developing, but just they get into so much stuff and they put so much stuff in their mouth.
Yeah, sure.
Is the uvula?
I used to work with a. What was that?
I'm sorry. Is the uvula the same function as the epiglottis?
No, no. It's just a piece of tissue that hangs from the palate.
Oh, okay.
What were you gonna say?
I used to work with a guy that his mom had been sick, went to the doctors, and they said, "Oh, you'll be fine." Well, one day I remember he just got an off shift. He goes home. His mom is pretty sick. He takes her to the ER. He drives her there, and as she's walking across the front door to the ER, she collapses, goes into respiratory arrest, ended up dying. They didn't diagnose the epiglottis or the epiglottitis. So. I'm going to skip over a couple things, but and we'll talk more about this when we deal with poisonings. If you inhale a toxic substance, or if you inhale something, can that affect the lung tissue and the structure of the lung?
Yes.
Yes.
Yeah.
There are some that can cause, for example, anhydrous ammonia, that can cause fluid buildup in the lungs, and we already know what that can result in. There's other chemicals, for example, for you firefighters in here. Why must you wear an SCBA when you go interior, and not just because of the heat? Or why should you even put on your BA when you're doing overhaul? Come on, Kevin or Andrew or Frankie.
Carries carcinogens.
What else? Yeah, it's cancer causing stuff, but there's something more important. What are a lot of the household products made out of nowadays?
Hydroperoxide.
Of what?
Hydroperoxide.
No.
Chemicals.
Well, yeah, but there's other stuff. How about synthetic materials? Right?
Like the couches.
Uh-huh. And let's talk about plastics. Is that synthetic?
Yes.
Yes. What's a byproduct of burning plastics and thus synthetic materials?
It's hazardous because of the smoke it makes. It's bad to inhale.
Okay, what's in that smoke?
Is it carcinogens?
Besides carcinogens, there's something worse. It's gonna kill you way before the cancer does.
Is it the sulfur dioxide?
No.
The smoke inhalation.
Oh yeah, I forgot about you, Rosie. Yeah, the smoke inhalation of what though? What's in that smoke?
The CO2.
Well, you got carbon monoxide, but something else. What do you say, Sequoia?
And hydrochloric acid.
Hydrochloric acid? Maybe, but there's something else.
But there's heavy
How about-
metals in it.
Okay. Well, what I'm referring to is cyanide.
Oh yeah, cyanide.
Hydrogen cyanide. What's cyanide do?
It kills you.
How?
It can kill you.
Yeah.
By poisoning you.
How?
Entering in the system. And ingesting it, I guess.
It basically suffocates the cells because the oxygen is not getting transported via the hemoglobin.
Yeah.
Just like carbon monoxide. Carbon monoxide has a greater propensity or greater attraction to the hemoglobin than oxygen does.
Yeah.
So it kicks oxygen to the curb, and it's not being transported via the hemoglobin.
Yeah.
Okay. The reason I brought that up is it's poison exposure. You inhale this stuff, you're gonna die. You can die. because you're literally getting suffocated to death because oxygen is not being able to be transported in the hemoglobin. Same thing with not just cyanide, but same thing with carbon monoxide.
Yeah.
What's the thing about carbon monoxide?
Well, it's the same thing. You inhale it, too much of it, and it can kill you.
Okay. But you'd be like, oh, I'm inhaling too much carbon monoxide. I need to get out of here.
No,
No.
because you can't see or
Yeah.
smell.
Yeah, it's colorless, odorless gas.
Yep.
One of the signs and symptoms of carbon monoxide poisoning is a headache and drowsiness.
Nausea, right?
Yeah.
Nausea, yeah. So if you start developing a headache, start getting drowsy, it's a bad sign. The other thing too is if you're already asleep and you're inhaling the carbon monoxide, what's going to happen is that you probably won't wake up.
Yeah.
You'll die right there.
Like when you leave the stove.
What was that?
Like when you leave the stove on.
Well,
not the stove, but the.
I just did. Hello? Hello?
But I guess the either the burner, whatever. I don't know.
Sorry, I couldn't hear you.
Oh, I guess like when you leave when you leave the stove running, like the burner without, just open, whatever.
Well, that's natural gas that it's displacing. Yeah, and there are some chemicals that will displace oxygen.
Yeah, but like you get pretty much the same symptoms, which is like you wake up with like a headache and you can like smell it. Well, that one you can smell it, but you wake up with like a headache and stuff.
Yeah, but they put that aftermarket. That smell is done after the fact.
Yeah.
So they know that there is a gas leak.
Yeah.
But natural gas doesn't have a natural smell to it.
Yeah.
Cyanide does. It smells like, anybody know?
Like rotten eggs, right? Isn't it?
Like what?
Rotten eggs.
No, that's sulfur.
Oh.
Like you're talking about like when you're burning it, or?
No, the smell.
Yeah, the
That's why.
smell of cyanide.
But it's because like how certain things have cyanide, like the seeds of an apple, like they have cyanide, but like you can't really smell it,
Peach pits, apricot pits.
Yeah.
But there's something else.
The smell of it, or what?
Yeah. Like roasted almonds, bitter almonds.
I don't even know what bitter almonds smell like.
Like old almonds?
Yeah.
Like when they're stale, or?
Well.
Well.
That makes sense now.
Yeah.
So whenever you're dealing with any type of poisonous exposure, remember it's going inside your lungs, and so it can cause damage. There are some caustic substances that will burn the airway. Superheated gases also will burn the airway. With that, there's another saying that I have, and that is that traumatized tissue swells. So if you're inhaling superheated gases, what do you think is going to happen to your airway?
Cut off.
Constrict.
How? You burn it, and so it's going to cut off by the swelling. Okay.
And that's what I was talking about.
What?
The question asked you earlier.
About not looking at the airway?
Yeah.
To be honest with you, I hadn't heard that before on anything, but
I think
things
I was
change.
the subject.
Okay. All right, so Valeria locates Mrs. Brown's medications, finding that she has both meter-dose inhalers and medications for use in a small volume nebulizer. Jake questions, or I'm sorry, Luis questions Mrs. Brown about her recent use of the medications to determine if she is eligible for additional treatment, as Valeria consults a drug reference to confirm the nature of the medications. Luis consults medical direction and receives an order to administer medication from the meter dose inhaler. As Valeria assists Mrs. Brown with medication, Luis completes baseline vital signs. Then they assist Mrs. Brown to the stretcher and prepare for transport. Valeria reassesses Mrs. Brown en route to the hospital. No, I'm sorry, this is Luis. Reassesses Mrs. Brown en route to the hospital, noticing some decrease in excuse me, some decrease in the wheezing and a respiratory rate of 24, with a pulse oxygen 96% on 4 liters of oxygen. So is she getting better?
Yes.
All right. Okay. So any questions on any of these conditions? And I skipped over a couple of them. You're going to get more of the poisonous gases. You're going to get more pulmonary edema, pulmonary embolism, pneumothoraxes, asthma, COPD, that kind of stuff. Now, we were talking about the medications, and we kind of covered it with pharmacology. So I guess talking about albuterol, do you guys have any questions for me on albuterol, or do you understand what it does and what it's classified as?
No.
Yeah.
Oh.
So what don't you understand? So what is the classification of albuterol? What does it do?
Dilate your
Bronchi.
Okay. But it's classified as a bronchodilator.
Yes.
In other words, it's a beta-2 agonist which relaxes bronchial smooth muscle.
Yes.
Okay. Now, how is it administered?
Orally.
Orally?
Yes.
Yeah.
Yes.
It's inhaling.
Yeah.
Okay. It's inhaled via
The meter dose inhaler.
meter dose inhaler or
Small volume nebulizer.
Yeah.
or small volume nebulizer or just a nebulizer. Okay. There's also a spacer. What does a spacer do? The spacer spreads out the dose, so it's given over a longer period of time, as opposed to just the inhaler itself.
Yeah.
That's it. You put it in at the end of the spacer, you squeeze it, and it spreads out. So they're getting more of the medication. I mean, it's still the same amount, but it's just spaced out longer. And that's what they call a spacer. If you look at your book, it's figure, I don't see a figure number, but you'll see the meter dose inhaler in the center, and then 2 types of spacers, and then you see the inhaler being put at the end of the spacer. You guys see that?
Yeah.
You guys got to practice with the nebulizer mask and the nebulizer itself?
Yes.
Okay. Nowadays, we're gonna have to be careful with the mist coming out of a nebulizer because it could have a virus in there, COVID-19, for example. So as they're inhaling it or exhaling it, they're putting the virus into those droplets. Now, I've seen both where that could be a bad thing, and I also read something that says that's not really true. So just I want you to keep in your mind that it can be bad. So make sure you're using respiratory protection.
Yeah.
When would we use an inhaler?
When they're having an asthma attack.
Okay, or
Like a respiratory distress.
okay. When would we not give it?
When they don't need it.
Okay. If they're not conscious for it,
No.
if it's not theirs, for example, if I have an albuterol and Sequoia needs it, I can't go and say, all right, here guys, use my inhaler for her.
No.
Okay, it has to be the patient's own prescribed nebula or inhaler or medication. When they've already gotten enough albuterol, usually you can give about 3 doses. So what do you think the patient's going to experience? In other words, side effects. What are they going to get? What can they get?
Right now.
Wheezing.
Tachycardia.
All right, they'll get tachycardia. Why wheezing? Are you trying to alleviate wheezing?
Isn't it like crackling because the release of the mucus?
Well, it wouldn't be necessarily crackles.
Well,
How about tremors?
Yeah.
How about dizziness? Nervousness?
Dry mouth.
Dry mouth.
oh yeah.
It's getting hot in here. What's the dose of albuterol that you give?
1 bullet.
Okay. How much is in that bullet?
Um,
One.
$2.5 milligrams in 3 mLs of fluid. I'll be right back. It's getting really hot in my room. And I still have the ceiling fan on. It's getting pretty hot. I'll be right back.
okay.
Olha, Pedrita. Olha, Chimiquita. Okay, I'm back. All right. So Rosie, Rosie's my patient, and Rosie is 8 years old. Should I be concerned about her being in respiratory distress?
Yeah.
Yes.
Why?
Because her lungs are not fully developed.
Okay.
Deteriorate faster.
Okay. What does that mean? What do they lean on when they're having issues?
Their nose.
No, not necessarily their nose, on their respiratory system.
Their lungs.
They don't lean on the cardiac system like an adult does. So they're able to compensate very well. Huh?
The abdomen.
Okay, they may use, well, little kids will, like infants will use their abdomen because they're not fully developed. They're not that big. So seeing abdominal breathing is common, but not with older kids or adults. Another thing we don't want to see is like seesaw respirations. We don't want to see sternal retractions. In other words, that divot in the center of the chest with that greater pressure sinking in the sternum. So you show up, Rosie's your patient. What are you looking for?
How the patient is positioned.
Okay, what do you mean? Or how do you
Like,
mean?
is he tripoding or?
Okay, what else?
If the patient is on the floor.
Okay. Why the floor?
Skin color.
The floor because it means that that child is in pain, he's injured. Somewhere.
Okay, maybe,
Yes.
but not necessarily.
No.
What else?
Skin color. Are they cyanotic?
Okay, we want to look at their skins. How about the work of breathing?
Yes. If they're breathing heavy, breathing fast or slow, or how much other breath type, like if it's heavy or.
Well, what about also, are they lethargic? Are they struggling to breathe? Are they putting a lot of effort or no effort? Because they don't have the energy left to put the effort into breathing.
Yes.
Okay. The moral of the story is that kids do not do very well in respiratory distress. They will for a while because they compensate very well. It's when they stop compensating that becomes an issue. That's what we have to avoid. Okay. Mental status also, won't that give us information as to how good they're doing?
Yes.
Or how bad they're doing? Yeah.
Yes.
If they're lethargic, if they're drowsy, sleepy, they're not perfusing very well. They're not mentating very well. Okay. So respiratory distress, they're having issues breathing. They might have some retractions going on. They'll have accessory muscle use. But then in failure, what are we going to start seeing in respiratory failure with kids? Heart rate starts to slow down.
Yeah.
The blood pressure begins to fall. The respirations are irregular. They become limp.
Like exhaustion.
Uh-huh.
Grunting sounds.
So what do you think we're going to do for them?
Load and go.
By oxygen.
Hold and go. Oxygen. Remember, drug dose and route.
Yes.
No, not yes.
No,
Give me
no,
the drug dose and route.
Oxygen, via non-rebreather mask, 15 milliliters.
Okay. So O2, 15 liters via non-rebreather mask.
Yes.
And if that's not working, then what?
And
BVM.
BVM, yeah.
Now, remember that little kids don't like anything over their face.
Yes.
Would be younger than Rosie. They don't like anything on their face. So if you're able to put that mask on the face, what is that telling you?
There's something bad.
Something bad. So what can you do in order to give them oxygen?
Have the parent hold it near their face.
What do we call that?
Assisting the patient.
There's another name for it. No?
Additional resources.
No.
Supplemental oxygen.
What oxygen?
Supplemental.
I'm sorry, I couldn't hear you.
Supplemental.
Well, that's what we give everybody, but for kids where the parent's holding it for the kid, what do we call that?
Oh,
Blow by. We give them blow by oxygen.
low by?
Blow by oxygen. You hold it off to the side or you hold it in front of them away from the face. So they're breathing it in as it blows by them.
Low by oxygen. Oh, yeah.
Okay.
Sounds makes sense.
So now we have an old person like George.
Damn you.
I was gonna say Valeria, but I try not to pick on women and calling them old. Because knowing Valeria, she'd be like, "Screw you, old man. You're the old fart here, not me." So George is an old man. So I talked about this in lifespan development. So what's going to happen to him?
Wait, what was the question? Sorry.
George is an old man. So what are some of the changes we're going to see in him as an old man? And I don't mean old man like at 45. I mean old man like in his 70s or 80s.
Oh, like
or even in
grumpiness.
his 60s.
Grumpiness.
Alzheimer's.
What did you say, Rosie?
Alzheimer's.
No, that's not something that's automatic when you're old. No.
Cranky.
Yeah, because they don't get any anymore.
Oh man.
Oh.
Endorphins. No endorphins.
Yeah.
Do
I guess
what?
I guess the nursing homes are not working for him.
I guess not. Well, not right now. They're all shut down, remember?
I'm pretty sure he's probably sneaking into some other woman's room.
Very true. I'm sure you've seen that happen at where you work.
Oh yeah.
Wait, Sequoia, why does it always have to go to that? Why? Don't understand.
So what is happening physiologically? What's happening to the body as we get older?
It's
Specifically the respiratory system.
starts
Done down.
Okay. But I said specifically in the respiratory system.
it diminishes
What diminishes?
the respiratory function.
Okay. What else? How is it diminished? Loss of elasticity, loss of surface area, loss of a surfactant.
Isn't it more like when you get older, your immune system doesn't work?
Exactly. Your muscles aren't as strong anymore, so they don't get that full deep breath. What about all those years of environmental exposure to substances, smoke, smog, dust? Yeah, it catches up to you, damages the lung tissue. Okay. So Are they really able to clear out their airway as good as they used to?
No.
No.
Maybe they're overweight, and that's going to cause abnormal breathing as well. Bigger necks tend to have more issues breathing, and a higher incidence of like sleep apnea.
Yeah.
What else? Some of the other stuff is pretty much the same thing you're going to see with regular adults as well. The tripod accessory muscle use. So, the thing about elderly patients is they're going to also decompensate quickly because they don't have that strong defense mechanism anymore. So they can deteriorate very, very quickly. All right, same thing. They go respiratory distress, respiratory failure, respiratory arrest. You got to be able to recognize when the patient's going from distress to arrest. You may even see questions on exams that talk about that. You know, we'll give you a patient presentation, and we'll ask you how is this patient? Respiratory distress, respiratory arrest, respiratory failure. So be able to recognize that. So what do you think the treatment is? Really for anything. Huh?
Give him oxygen.
Oxygen. What else? Position of comfort.
Yes.
Transport. Maybe assist them with their own medications that you're able to assist with.
Yes.
Now, this is in general. This is really for all age groups. What are some of the signs and symptoms of respiratory distress?
Trouble breathing.
Okay, difficulty breathing or dyspnea.
Yeah.
And I mentioned a bunch of them right now too.
Failure, nose flaring, pulse width,
All right, cyanosis.
patient speech, mental status.
Okay, why is that?
For which one?
Altered speech, altered mental status.
It's because so they can, if they can speak, they kind of have like a clear airway.
Okay.
And mental status is if they have like confusion.
Yeah. It also shows their alertness if they're responding to
Yeah.
you.
And remember, if they're altered, lethargic, they're not getting enough oxygen to the brain.
Yeah.
Yes.
Okay. What else are you going to be looking for in their assessment?
The patient's face.
Okay. What about it?
Expressions.
Confused. Inadequate.
Nasal flaring, pursed lip breathing. How about on the physical exam? What are you looking for?
To see if their lips or if their eyes are like drooping, if they're responsive.
We keep talking about their mental status, and we've already established what can happen. What else? What about lung sounds?
Yes. Lung sounds.
Maybe diminished lung sounds, absent lung sounds, abnormal noises, crackles, rhonchi, wheezes. How about skin signs?
Yes.
Yeah.
Yeah.
How about the heart rate?
Yes.
Yeah.
How's the heart rate going to be?
Low.
Slow. It's be fast because he's breathing.
It's going to be fast.
Tachycardia.
Yes.
So what's the difference between adequate and inadequate breathing?
That's that's the difference is the breaths per minute.
No.
Okay, what else? Not just the breaths per minute.
No.
Inadequate or adequate?
Both of them.
Well, both. I want to know the difference between the two.
Well, inadequate is the positive pressure. And adequate
Okay,
is
that's how you treat it. But I want to know how you make the determination whether the patient has adequate or inadequate breathing. I agree. We're going to use positive pressure ventilation and inadequate breathing because they need the help. And we'll use like a non-rebreather or nasal cannula for adequate breathing because they don't need a lot of help. But how are you going to know whether they're breathing adequately or inadequately?
So open airway, their chest,
Tidal volume.
Okay, you guys are giving me broad strokes. I want specifics.
If
So,
it's shallow breathing, it's inadequate breathing.
okay, and what about tidal volume?
Good chest expansion.
Okay, so you have enough air to cause the chest rise or expand equally. But what about the tidal volume? At least 500 cc's of air? And, or inadequate would be less than that, 300 cc's of air, right? Because how much of that volume is actually being used?
Only a
Only
portion.
350.
Yeah, 150 of it is not being used. It's what do we call that? Fresh my memory.
Dead airspace.
Dead airspace. Yep. Do you want to look at the skin signs?
Yes.
Yeah.
Yeah. Why?
For color and temperature.
See if they're being perfused correctly.
Okay. How so? I want you guys to expand because we've talked about this. I want you to tell me so I know that you understand. Why is the patient becoming pale, cool, and diaphoretic? I'm throwing a lot of review stuff in here because, like I said, we're done with the foundational stuff. Now we're building the house.
Because it's tachycardia. It's when they show signs of pale or cool, clammy skin that you start to notice it, and it's the distress of the respiratory, so it turns into hypoxia.
Okay, but more specific. Let's get back into the pathophys. If they're not breathing adequately, what's happened to the carbon dioxide level?
Well, if they're not breathing naturally, it increases.
Increase.
It's going to increase. So what's going to sense that increase in carbon dioxide?
The baroreceptors.
Not the baroreceptors. Those measure pressure.
Chemoreceptors.
The chemoreceptors, right? And what drives us to breathe?
The brain,
And what else?
the heart.
Yeah,
Well,
it's coming
yeah,
from the brain.
Yeah, from the brain.
The carbonic drive.
What was that, Luis?
The carbonic drive.
Yeah, it's the carbonic drive. Remember, the elevated CO2 levels cause us to breathe, or also known as the carbonic drive. So we're going to start breathing faster. Number one, expel that excess CO2, but also get more oxygen in. Now, again, why is the skin becoming pale, cool, and diaphoretic?
They're going into shock.
Why, Rosie?
Because they're going into shock.
Okay. And
The body's trying to
compensate. How?
Okay, sorry. You said if there's getting too much CO2, correct?
Yeah. So remember that you're right. It's in shock. It's becoming hypoxic, not enough oxygen, too much CO2. So remember that the body's going to shunt to divert blood away from unimportant organs and try to maintain it to the core to perfuse the more important organs. All right? All this coming back to you?
Yeah.
Yes.
So I'm being terrible today, aren't I?
Yes.
Making you work. Oh, thanks, Sequoia.
You're making my brain hurt.
How do you think my brain is? And believe it or not, when I teach advanced classes, my head hurts afterwards. I got to think about all these advanced concepts and all these fancy words. Hey guys, the ones that are not talking today, Is all of this making sense? Please, I will take a message on the chat to tell me, because I'm just kind of reviewing a lot of stuff. And if you notice, we've talked about the majority of what we talked about today, did we not?
Yeah.
Previously to this.
Yeah.
Okay. So
Yeah. Are you
the
gonna be posting
concepts,
this one on YouTube too?
yeah.
All right.
But what I want to know from those that are not talking, basically, if your camera's not on, you're not talking. Except for Rosie. She's always talking.
I'm not always talking.
Yeah.
I'm the quietest person in this group.
Oh, I don't think so. Jennifer has you beat by a mile. Okay. So somebody told me that, yeah, it's making sense. Okay. How about for the others? Amber, Elena, Ashley, Jennifer, Marcus, Kevin, Josh, Gerardo.
Yeah, makes sense.
Okay. Are you guys able to keep up? Is this like kind of bringing back memories and kind of also helping you see what you have to really reinforce?
Yeah. Especially the respiratory.
Uh-huh. Now, tomorrow when we talk about cardiac emergencies, we'll talk about acute coronary syndrome, which is angina, which is heart attack. We've kind of talked about heart attacks, but if the heart muscle is not able to pump adequately, what's going to happen? We've talked about the heart before. Pump the pipe and the fluids. I just got a message that they're liking this a lot, so I'm glad you're liking it. So again, if the heart muscle, the pump is not pumping adequately, what's going to happen?
Loss of oxygen.
Exactly. Remember, I've told you guys, blood equals oxygen.
Yeah, blood equals oxygen.
So if there's not enough blood being circulated, what is also not getting circulated well enough?
Oxygen.
The oxygen. Therefore, what's going to happen to the body?
It's gonna start shutting. We'll start shutting down.
Yeah. Again, it's going to shunt. Heart rate's going to go up. Respiratory rate's going to go up. Nasal flaring, accessory muscle use.
Yeah.
You see how all of this ties in together?
Yeah.
Yeah.
Yes.
Yeah. And when we get to allergic reactions, we've talked about that distributive shock. So what happens to the blood vessels?
They constrict.
No.
Oh, they dilate.
They dilate. They vasodilate. So what happens to the capillaries? We talked about this earlier. I remember. Remember the capillaries? They start
They become
leaking.
permeable.
Oh
Yes,
yeah.
they become permeable. They start to leak. That's what causes pulmonary edema. That's what causes laryngoedema. That's what causes angioedema. If you saw the movie Hitch, remember when he had that fish and he was allergic to it?
Oh yeah. So.
And his face swelled up?
Yeah.
Okay, that can happen. It's a dramatic exaggeration, but still, you can have body parts that swell up. So you see how things that we've learned in the past are coming into play now?
Yes.
Yeah.
So that's why it's very important for you guys, and I had said this earlier too, back when we did it. It's important for you guys to grasp the concept. That's why I want you guys to ask for help. That's why I want you guys to understand what we're talking about. If you think I'm going too fast, speak up or send a message and say, Lou, slow down. Or Lou, can you explain it differently? Or Lou, I didn't quite understand it. Can you explain it again? So I don't know what to do unless you guys tell me what I need to do. You know, now we're, the day class is a little bit faster because we meet for 4 days a week. So we're already in medical emergencies. Sometime next month, you guys are going to go out onto the ambulance. Believe it or not, there's former students of mine out there that you're going to ride out with. And they know what I teach, and they'll ask you things. What was that?
What chapter is the other group on?
Tonight we're going to start airway management. So chapter 10. Yeah, it's chapter 10. So they're a little bit behind you guys. So you guys are kind of like my guinea pigs for the night class.
When will be our next skill?
Let me see.
What will it be on?
It's going to be on medical emergencies, patient assessment, medical emergencies. Let me find.
What was our question?
Is it next week?
I'm
No,
looking. I'm trying to pull up my schedule.
I think it's scheduled for the 15th of June. Looking at the schedule that you gave us.
Yep, 15th of June. You have 2 exams before then. So we'll finish medical emergencies before you guys have another skills day. Tomorrow's cardiac, and then ultramouse, stroke, headache, seizures, and syncope. Acute diabetic. Man, that's a tough chapter.
Diabetics?
What was that?
What did you say it was a tough chapter?
Well, actually, a tough section.
Like part A, you mean? For
Yeah,
medical
9A.
medicine?
Yeah. You got cardiac, you got respiratory, you got strokes, you got seizures, you got diabetes. That's rough. So I want to hear from you guys what you guys think. Of course, my computer's being slow. You guys are bugging down my computer.
Anyone?
Right. Let's hear from Josh. We haven't heard from him all day long.
Wait, did he say something? No, he did say something earlier today.
Barely, like 2 words.
True.
I've been saying answers throughout the whole thing. No one hears me. And it's loud as hell here, so I don't turn my mic on.
Yeah.
Chilling and studying. Nice.
I have a 50 question exam and a 72 question exam.
Jeez.
Ooh, wee.
72.
I might try the 72.
Damn. Way too many.
50's too easy. But I'm trying to remember why the big difference. Oh, okay. Oh no, that's why, because I threw in. Yeah, I want to use this one because it has a refresher pathophys stuff on it. Yeah, I'll do that. You guys will get the 72 question exam.
Jeez, you're trying to kill us.
No, I'm trying to make sure you guys study, but
As much as it already does.
what was that?
Then my brain already does stuff.
But you know what? When you're done, you'll be like, damn, Lou really taught us a lot and he knows his shit. Or is that wishful thinking?
Wishful.
Ah, thanks. I could feel the love. What I'm trying to do is connect the dots
Yeah.
to show you, because I could show you PowerPoint all day long. You laughing at the echo or are you laughing about the PowerPoint all day long?
The echo.
Yeah.
There you go.
Yeah, it drives me nuts sometimes.
Is your
But-
forest on fire?
Huh?
Is your forest on fire? in
It
the
looks
background?
like
What for it? What are you talking about, Willis?
The one behind you.
No, that's
kind of background you have.
those are the flowers growing. The poppies, the California poppies.
It's because the mist looks like smoke. That's why.
Yeah, it is smoke.
It's early in the morning. It's the cloud cover. It's
Red?
the morning mist.
Watch,
It's
look
on
at it.
the right side,
It's-
there, right there.
No, that's not mist. It looks like a fire or like a smoke.
No.
Someone burned their
It's mist.
s'mores. Oh, that sounds good right now too.
No, it's Luis's vape. That's why it looks like that.
Girl for today.
Maybe it is. So I guess we're going on a strike team. Have you guys ever been on a strike team?
No.
No.
Nope.
It's pretty interesting. It's a lot of work. I was a task force leader and stuff, division group supervisor, and a lot of work. I kind of miss those days, but I'm over it. Even though Clint wants me bad, but I'm not going to do it. I have no time for it. So, in all seriousness, for the quiet ones, please, please, please let me know. Is this working, not working? What can I do differently? Are you guys okay with the way it's being done? You feel like you're a little behind. What can I do to help you? Besides putting the videos on YouTube.
It says that Josh is being creepy right now.
Josh has been creepy, how?
You missed it.
Probably did. All right, good. Somebody else sent me a message. It's working, learning a lot. All right, good. So, that's although the scenario in that case study that we were reading was very similar to our scenario that we worked. But did that help to kind of see how things are working? Or better yet, did that help?
Like understand more.
Yeah.
Yeah, and actually applying the knowledge that you guys have already attained.
Yes.
That helps see how it comes into play.
Yeah.
I just said to review more.
Okay. So I think that was maybe one of the unintended consequences, objectives of today, is to see what you guys need to review, go over and try to reinforce to keep that knowledge in there. Because like I was saying, with cardiac emergencies, it's almost the same thing. It's a lack of blood flow, which in turn, it's a lack of oxygen flow.
Yes.
With a stroke, a CVA, it's the same thing. There's a blockage or a bleed. And so part of the brain is not getting that oxygen. So it's just learning what the signs and symptoms are of that. Yeah, the brain is not getting the oxygen, but now we're going to talk about the functions of the brain and what you might see as signs and symptoms.
Yeah.
With seizures, it's a short circuit, so to speak, of the brain. where a lot of different things occur, including what they call a tonic-clonic seizure. So what you've seen when people tense up and they start to shake, that's what we call a generalized seizure or a tonic-clonic seizure. It used to be called a grand mal seizure, but we got away from those names. But understanding that they're really not breathing during that period of time. And again, going to the loss of blood flow to the brain during that period of time. Also knowing that because the muscles are contracting very, very rapidly, they're using up a lot of energy. So that's one reason why the person afterwards is lethargic. We call that postictal, because they just did the equivalent of running a marathon in a matter of seconds or a matter of minute or so. So again, that concept is there, but understanding that there's something else going on in the brain and what you're going to see. Okay. So don't hesitate to ask for additional stuff, additional work. I could send you guys like a workbook type of thing or a packet for you to work on. It could be matching, quiz questions, it could be vocabulary, it can be a scenario to get you to think. And again, hoping that you identified. That's driving me nuts. Hopefully, it helped you identify what you're needing.
We can have access to the exams that we've already taken.
Hold on, I'm sorry. What was that?
That we can't have access to the exams that we've already taken.
Only if you make an appointment with me and go to the office and do that.
Okay.
Because I have no way to control whether you're taking pictures of the questions or not.
That's a good way of doing it.
Oh.
So the best thing is make an appointment with me to go to the office and review your exam. And I could review it with you. We could see what you missed and we could go over that question. I did that with somebody yesterday.
As far as the package for the CPR, can you send that out to the ones who don't have them?
What, the books or the code?
Well, are you going to do both?
Well, Michelle needs to send those codes. She's the one that deals with the CPR stuff, so she gets those codes and then she's going to email them out. I'm going to stop by the office in a little bit, and I will talk to her about setting out those codes. As far as the books, we didn't have. I only had 3 left, so I got to wait for them to come in. Once they are, then I'll let you guys know so you guys can stop by the office and pick one up.
Okay.
That way, you guys can start reviewing, reading it, and get ready for CPR. And then we'll probably schedule it in a couple weeks.
Okay. Well, that's fine.
Okay. It'll probably be after class because I don't see when we can kind of do it. And we're going to limit it to 6 at a time.
Okay.
So I'll have to get those dates from Michelle as to when she can do a CPR class. Okay. But yeah, I'll talk to Michelle about it today. Anything else?
Well, I mean, I think that a good way of learning is by doing that, the scenarios more often. But I think like the
And I intend to do
that
more.
you said last time really helped out.
Scenarios gives like a more brief explanation of stuff instead of like explaining like certain things or like reading from the book. Scenarios help you like grasp the concept or whatever, like more better. I think that's just better.
Okay. Yeah, I will definitely start doing more of those. So.
All right.
The PDF that you sent last time really helped out.
Which PDF?
The email.
The one with all the terms and so we could review and study.
The one with the questions and the acronyms?
Yeah.
Okay. So if I have other stuff, I will send it out to you. I will do more scenarios with you guys. I'll review the stuff. But you also have to read though, and because that's part of the flipped classroom concept, is where you guys read ahead of time, and so you're ready to answer the questions. Again, using the scenarios, when a question is posed to you, you understand and you're able to answer, just like we did today.
Yeah.
Although we were tapping on information that you guys had already learned in the past. So, okay. All right. Anything else? Alrighty then. All right. Well, then I will see you guys tomorrow morning. I will have a quiz for you. We'll do another scenario or two, and cover cardiac emergencies.
All right.
Okay.
Okay.
All right.
Hey,
I
Lou,
will see
can
you
you
guys
send
tomorrow.
can you send the email out with the PowerPoint for tomorrow's chapter?
Yeah, I'll do that shortly. Yeah, I will definitely do that. In fact, I'll start doing it now. And my thing is slow. All right, I will see you guys tomorrow then. I'm working on sending you guys that PowerPoint for tomorrow. So review again, quiz tomorrow on on respiratory emergencies.
Yes, sir.
All
All
right.
right, sounds good, Lou. Have a good one.
Sounds good, Lou.
Yeah,
All
good
right.
day, Lou.
Thank you. You guys
Have a
too.
good day.
There, Lou.
Bye, guys.
I subscribed.
All right. Yeah, I saw that.
You did? Okay, let's go.
Me too.
All right. Later, sir.